I would like to invite our next speaker, my friend Sountoulidis. Please proceed.
Dear Andreas, Thanasis, thank you very much for this very honoring invitation. It is a pleasure and a privilege to be among such distinguished faculty and masters of enucleation, actually. I don't consider myself a master of enucleation. I just started doing BipoLEP a couple of years ago, and I'm going to, after those fantastic lectures on lasers in enucleation, I'm going to try to convince you that this procedure can be done without using lasers. So, we are actually doing the same thing. As we used to do in open surgery, in open prostatectomy, we need to find the plane between the capsule and the adenoma and trying to peel the adenoma off the capsule. In BipoLEP, bipolar enucleation, we do that using the blunt metallic tip and this specifically designed Thomas Hermann loop. So this is the enucleation plane. We need to remove the adenoma from the compressed peripheral zone of the prostate. And why are we doing that? Why is this discussion going on? Why is anatomic endoscopic enucleation of the prostate the new best thing for some patients, not all of them? Because TURP is not the gold standard anymore, not for every patient, because there is, in TURP, there is a very subjective surgical goal. You're trying to remove as much adenoma as you can in a limited time. There is certainly a size limitation, and as mentioned before, there is the risk of leaving residual adenoma and the need for a second operation. Whereas in enucleation, there is an objective surgical goal. You will need to remove, enucleate the adenoma with excellent and durable results and no size limitation. As you can see, you can do enucleation starting from 40 mLs of prostate and going up to very large prostates, more than 150 mLs. And again, this is evidence in favor of the durability of the result of enucleation. As you can see, the larger the prostate gland, the less efficient TURP is compared to enucleation. And again, since TURP is not an anatomical procedure, we are not removing the tissue as we should, as we are removing the tissue in anatomical enucleation. There are troubles. We can go either too deep, causing capsular invasion, perforation, bleeding, or even fluid absorption, or what usually happens is we go too shallow and we just leave residual BPH tissue behind with problems of regrowth and need for second operation, or even problems of constant dysuria following surgery. As in this case, this gentleman had a TURP 2 years ago. He came to my office with complaining of LUTS, obstructive LUTS. As you can see, I had trouble going inside with the scope. As you will see that he has an open bladder neck. However, there is regrowth or residual BPH tissue. That's the bladder neck. And as you can see, there's tissue left behind following TURP. So this patient will need a second operation, which will never happen following enucleation. So what will you need in order to start doing BipoLEP? If you got a bipolar electrosurgical unit, the only thing you need to do to buy actually is buy the motor system, the Morselation, the handle of the Morselation, and of course the blades. You will need to have a nephroscope and the suction, but this is not a problem. On average, you will need 20 to 25,000 euros if you got a bipolar electrosurgical system in order to start doing anatomical bipolar enucleation. So it's not as expensive as buying a new laser. And this is the BipoLEP setup. The only thing that is added in the standard setup for TURP is the nephroscope and, of course, the system with the Morselation. Right, this is a specifically designed loop by Carl Storch, but actually by Thomas Hermann. And this loop works in different ways. It's something like a multi-tool. You can use it to resect tissue, vaporize tissue, coagulate tissue, or even push or probe tissue in order to find the right plane. The same, or actually a similar loop, has been created by Richard Wolf. However, you can do enucleation even if you're working with the Olympus system. In this case, you don't have a morsellator. However, you can use this specifically designed loop with this plastic black sheath in order to push tissue, and then after the tissue is being kept attached to the bladder neck, you can just resect it without the use of a morsellator. But 3 different types of morsellators. The one I've been using is the drill cut from Karl Storz, which works as like a pendulum clock with an oscillating movement. There's also the Piranha from Richard Wolf, which has a rotating tooth plate, and the VersaCut from Lumenis, which has a non-tooth plate with different movement, reciprocating piston movement. Morselation was an issue in the past where the older generation morsellators were quite slow. However, with the new generation morsellators, you can expect morselation efficacy or speed of 11 grams per minute, which adds up to 10 or 15 minutes of morsellating a 100-gram adenoma. Right, for irrigation, we just need normal saline throughout the procedure, having the irrigating bag at 30 to 40 centimeters above the patient level during enucleation, and at 80 to 100 centimeters during morselation for full bladder distension. And again, during morselation, you'll need a second giving set through the nephroscope in order to keep the bladder full at all times. What about the general use of enucleation? You have to make the procedure as simple as possible with this specifically designed Thomas Herman loop. You can cut, coagulate, vaporize, enucleate, or even probe or push tissue in order to find the right plane. By experience, you will need less energy because you will be able to find the right plane, and you'll certainly need to respect the anatomy by recognizing and sparing anatomical structures, of course, the verumontanum, the sphincter, and of course, the UOs. So let me guide you through the procedure step by step, the BipoLEP procedure. This is the way I was taught to do BipoLEP with 3-lobe or 2-lobe technique, starting with an incision of the urothelium around the veru in order to find the right plane between the adenoma and the capsule, starting then by nucleating the middle lobe if there is a middle lobe. If there is no middle lobe, just creating a 6 o'clock channel, proceeding with the left lobe enucleation, then proceeding to commissurotomy or resection of the anterior part of the prostate in order to separate the lobes at 12 o'clock. Following that, you need to release the sphincter from the adenoma, proceed to right lobe enucleation, and then once both lobes are pushed inside the bladder, just do hemostasis and finish with the morselation. So this is the first step, at least the way I do it. Incision of the mucosa at the bladder neck and the prostatic apex, making a groove from the bladder neck towards the apex, as you can see, with this very nice and handy loop. You actually do a U-shaped incision around the verumontanum, because this is the area where you easily find the plane, the capsule. As you can see, you usually just need to gently push, and you arrive at the right plane. There's usually a bit of bleeding to start with, because this has to do with the fact that you're cutting the urothelium. There's not much space for irrigation, especially if the patient had a catheter. As you can see, a small prostatic nodule on the left. You can go on and actually continue this dissection on the left side or right side if you're left-handed, trying to prepare the left lobe. And then what you need to do, at least what I'm doing in my practice, is to do 2 incisions at 5 and 7 o'clock, as you can see, go inside the bladder, have a look at the UOs, and then do incisions at 5 and 7 o'clock. All the way down to the plane that you have already created or identified. These are full thickness incisions because there's a lot of tissue there. And then you arrive at the plane that you have already created around the verumontanum. There is always some ridges of tissue which you will need to resect. And you continue with the same incision on the other side of the middle lobe, if there is a middle lobe. Right. So the next step, if there isn't a middle lobe and you want to take the middle lobe separately, you can do it by taking it the middle lobe with the left lobe or the right lobe. However, if you're starting doing BipoLEP, this is a nice area to start. Just do the middle lobe, for instance. It is safe. You don't have to mess with the sphincter. As you can see here, you are now pushing the middle lobe towards the bladder. This is the right plane, as you can see. It's easy to identify the right plane. It looks like inflamed mucosa, like Thomas Herman said, and you have those penetrating vessels that look like this. So you need, at some point you will need to cut and proceed with pushing the middle lobe inside the bladder. You always check the UOs because, as you can see, the middle lobe is now inside the bladder. So once you're away from the UOs, you can safely resect and lower the level of the bladder neck. And, sorry, that was the previous one. Okay, now it's moving. So the middle lobe is inside the bladder. Check the UOs again. And what you need to do at some point is just try to thin it in order to finally decapitate it and push it inside the bladder. I'm just going to show you here. That's the final part. It just keeps hanging from a small amount of tissue. And once this is cut, it's free floating inside the bladder. Right, so the next step of the procedure, if you're doing three-lobe technique, is to create the plane on the left side if you're right-handed, which is usually the case. Not sure why this is not. Is there something I can do from here? Okay. That's fine, we can move to the, okay. Yeah, I can see that. Okay, I will have to skip that part. The second part, the next step is the separation of the two lobes and release of the sphincter, which is not something that we do when we start the procedure. So once the adenoma on the left side, the left lobe is more or less released, then you stay at the level of the verumontanum. And you try to find the sphincter. So we mark the sphincter, and we start doing resection from the bladder neck to the sphincter. So there's not a lot of tissue usually at 12 o'clock. And at some point you will reach the capsule. Then what you need to do is free the adenoma from the sphincteric muscle fibers. Actually, there it is. This is the sphincter, and this is where you need to cut and leave some tissue on the sphincter. So cutting here, just leaving 1 or 2 centimeters of tissue of adenoma attached to the sphincter. And then what happens is that we need to merge those two planes. We need to cut the urothelium all the way back to the resection site, to the 12 o'clock position, as you will see. So going back, cutting the urothelium. So in contrast to BipoLEP, this is, we don't do an early sphincter, at least I don't do an early sphincteric release. There you go. And then once you are away from the area of the sphincter, you can start enucleating the upper part of the lobe by pushing it down, as you will see in the next video. So following that, you're safe and you can push the rest of the adenoma down. Right, so once this is achieved, then you'll stay to 12 o'clock position. And like I said, you push the left lobe down, in a downward movement. As you can see, it peels nicely here. And the next thing you will need to do is to merge those two planes, the plane that you have already created at 12 o'clock with the plane that you've created on the lateral side of the left lobe. This is not always easy, but by experience, you will finally be able to merge those two planes, as you will see later on. As Dr. Mizrahi said, you literally dance around the adenoma, finding any areas that the adenoma is attached to the capsule. As you can see here. And once you feel that it is completely or almost completely free, then you push the adenoma towards the bladder. I'm going to the end of the video. There, the adenoma is pushed inside the bladder, the left lobe, and as you will see, it's only attached by this bridge of tissue. And the left lobe is now inside the bladder. The procedure is repeated on the right lobe. And finally, you end up with a prostatic cavity that looks like this. There's usually a small amount of bleeding. However, you will need to be very meticulous in hemostasis because it is difficult to have good vision through your nephroscope while you're doing the morselation if there is significant bleeding. That's the final touch. And the morselation is the last part of the procedure. Like Dr. Mizrahi said, it's not the part when you get to relax because disasters can happen during morselation. So those are the rules for safe morselation. Have meticulous hemostasis, keep the bladder full at all times with the second giving set through the nephroscope. You need to stay in the middle of the bladder with your blades facing upwards, and always be sure that you have prostatic tissue engaged between the blades when the blades are moving. Never morselate a piece that is attached. And last but not least, I would say the most important is to train your OR staff and let them know that this is a very crucial part of the operation. Right, so what next? You put a 3-way Foley, 20 or 22 French with 20 mLs in the balloon. And just keep the irrigation for 3 to 4 hours and then talk the patient next day with excellent results. As you can see, this upside down. This is a patient with a 50 mLs per second Qmax a month following enucleation, BipoLEP. So how to avoid or deal with complications? This is a very nice discussion. I'm going to just briefly touch on some issues. I rarely had a case of capsular perforation with BipoLEP. A couple of times I had to use the rollerball for cases of bleeding from the venous sinuses. I normally give Lasix at the end of the case. With BipoLEP, as was mentioned before, it's too difficult to damage the UOs compared to the laser. However, if you're not able to see the UOs after, or you have some second thoughts about the UOs, then you should just do ultrasound at the end of the case. I've never had problems with BIS balls. Those are very small and actually very thick pieces of tissue which you cannot remove through the Morselator. Just need to use graspers and remove them. Urethral strictures, the same incidence as with bipolar surgery. And this is a long discussion on how to deal with patients on TOACs, newer anticoagulants. I just ask the patient to stop 3 days before and start within the next 2 weeks if the urine is clear for more than 48 hours. Just some couple of advice for colleagues who would like to start doing enucleation, bipolar enucleation. Don't hesitate to convert to TURP because it takes like seconds to convert to TURP. If you're doing bipolar, you just change the loop. If you feel that the anatomy is unfavorable or your level of expertise is not that great, it's okay to do subtotal enucleations or even one lobe enucleation in the start of your learning curve and have a low threshold for bringing back the patient for clot evacuation or bleeding in your initial learning curve. This is a problem I had with in the couple, actually that was the last case of nephroscope malfunction. So the adenoma was pushed inside the bladder. The nephroscope did not work. Actually, it was, you couldn't see through the nephroscope, so I had to resect the tissue inside the bladder. You can do that, or you can just put a catheter and ask for a new nephroscope. This is not the case in Greece. You will need to order a new nephroscope. This will take months. So I just sat and tried to resect the enucleated prostatic tissue. This is not always easy. Sometimes it is tricky because the tissue doesn't stay, and you will have to actually push the tissue towards the beak of your instrument to take good bites. I had, in terms of complications, I had 2 cases of bladder injury during my learning curve. That was due to OR staff, like mentioned before. They forgot to replace the irrigation. So I would like to end with a couple of pros and cons for BipoLEP. It is, for me, it's a very familiar technique to the average urologist who would like to start doing enucleation and has significant experience with TURP because you can easily convert to TURP in seconds. And in terms of cost effectiveness, is more affordable than HOLEP. However, as you probably watched in the videos, it's less precise technique of cutting tissue. And if you got bladder stones, you will certainly need some kind of laser, preferably HOLEP, in order to deal with the stones as well. And I will leave you with a famous quote from experts in enucleation. I do believe that we're moving towards the era of anatomic enucleation of the prostate, irrespective of whether this is done with electrosurgery or laser. I think that we should forget the term gold standard for TURP. As Dr. Gomez-Santos said, it discourages change and improvement. And a very nice editorial authored by Dr. Misrai, saying that we have to distinguish familiarity, which is what we're used to be, what we're familiar with doing, to what is the best thing that we can do and offer to the patients. So move away from what we're familiar with to something that is actually more efficacious in terms of symptoms relief. Thank you very much. I like this cartoon. It's from a friend of mine, Yannis Kartalas Goumas. It shows how you can do enucleation in like 5 seconds, something like that.
Thank you very much, Petros, for this excellent presentation. In fact, I have to say thank you very, very much also for your friendship. You have a lot of merit because you are working in a public hospital where time is very important. And when you have to start a new activity, I think it's always difficult to take your time to convince the anesthesiologists and the long lists of patients that you are doing something that is best for the patients, and you have to continue. So all these problems you are describing, the second nephroscope or things that should be a non-problem, sometimes it's very difficult, and for your time and for your heart, it's difficult to.
Thank you. Yes, yes, Andreas, you're absolutely right. This is a problem that we have in public hospitals. For instance, my nephroscope is broken, and there's a problem with storage equipment. It will take like 3 to 4 months to have it replaced. So just tip of advice, if you're going to do BipoLEP, buy 2 nephroscopes to start with, because it will eventually break or malfunction at some point. Yes, it is difficult to do BipoLEP in public hospital, the waiting list, the pressure from the anesthesiologist. My first cases with my mentor, Professor Sountoulidis, it took us like 3 hours, 3 hours and a half. So yes, you will need to be patient. And like Dr. Gomez-Santos said, you will need to be committed. Otherwise, you will not do anything.
Can I have the microphone to Dr. Meneghini, please, who is our international expert in BipoLEP?
Thank you very much indeed. Many compliments for your presentation. I would like to make some remarks about BipoLEP. Starting late 2013 in a very small hospital in Italy, like Christopher Columbus, left the port of Cadiz, fleeing west with no maps, with no GPS systems, trying to do something that could resemble what I saw done by Fernando at the top gun of the whole surgery, try to replicate it with a simple semilunar resection loop. Okay, and thereafter we met with Thomas Herman, and we acknowledged that we are doing exactly the same thing. He was working in a very huge hospital. It was a lot more of possibilities and option to be done, and I continued to working in a small hospital. But what I strongly support is that today BipoLEP is fully included in the family of AEP. I mean, there is no difference in technique, and there is not a variant of TURP. Because this is the most important mistake that you could do, because you can forget, because TURP is a playing snooker, to and fro. Enucleation, whatever technique you're using, is a swinging technique, like playing golf. And this is the first difference, complete difference from TURP. The second one is that I am a sort of bastard enucleator, because I started with BipoLEP, but 3 years ago I had laser too. And so I transferred my experience with BipoLEP in my laser surgery and to some of the laser surgery into BipoLEP. And I mean that the first thing to do, as Fernando has clearly stated many times, is to put insecurity in the sphincter. So the first time to do is put the sphincter in the safe. So disconnect the mucosa to avoid tearing. It's so reduced the incidence of early urinary stress incontinence. And after you can do anything, because as Petros rightly stated, is that BipoLEP is much more blunt technique, because the Herman loop is a very nice instrument for blunt section. If you're doing things blunt, the risk of tearing the sphincter are much more probable than using a laser. So my opinion is that first thing to do is to put the sphincter in safety, and thereafter you can do anything you want. And there, in recent times, I applied the suggestion of Thomas Herman on leaving the dorsal flap, mucosa flap. So I did it inside at 12 o'clock, and inside at 11 and 1 o'clock, and I leave this slide on mucosa. And this is another very important jump to maintain sphincter integrity. Herman loop is very nice. It's a very nice instrument. Has an excellent hemostatic properties. And the last thing I want to say is that a very important thing for any of these techniques, you should be humble. If I'm not able to do that, I cannot pretend to do anything at the first time. I gotta study a lot, so a lot of movies. But the most important thing is to have a proctor. I gotta have someone who's with me. I go to his hospital and he comes to my hospital to let me do the things for the safety of the patient first in the proper way. And this make me the possibility of a less steep learning curve. Otherwise, it can be very frustrating. And a lot of people in the past start with HOLEP. They bought a 100 watts audio laser that was put in their basement and forgot because they have a so elevated, so huge urinary incontinence after that they abandoned the technique. The technique is absolutely outstanding with any tulip, holmium, green, whatever else. It's nice. It's nice, and I think it is actually much better, even in the long period, because I have some operation made in the 5-7 years ago, where a huge percent falls today, and the patient is very happy about that. But I think that tomorrow, if Star Wars and you will allow me, I don't know which is the medium proficiency in this technique of the audience, but these people are coming today, probably they are not so expert like Professor Roche or Fernando in the business. And so I will try to perform, as Petrus has shown, a sort of 3 lobes techniques, because it's much easier to learn the in block that I do perform, even with laser and with bipolar, is a part of arrival. It's not a part of starting. It's difficult to teach in block technique from the beginning. Probably it's better to start with something easier, and thereafter you move to something more complex. I don't know if the other panelists agree with me, but if you allow me tomorrow, I will try to do that. Okay.
In fact, we are eager to see your technique tomorrow morning, and of course, we will have the possibility to discuss the different techniques and possibilities. And this is a master class where there are mostly trainees, so colleagues that need to learn, need to choose what technique they are starting with, if they buy a holmium, a thulium, or if they start with their basic bipolar source of energy. So it will be very important to see you.
We will perform an exercise of surgical democracy, since democracy was born in Greece 2,500 years ago. So we put people in the agora and we'll decide what to do, okay?
And at the end of the meeting, we will vote. And everybody here and the online colleagues that are seeing us, they are more than 100 inscriptions. So we'll try to see what they are choosing and who convinced them.
I'm gonna vote for my friends, not for the best.
I don't know if Professor Giannakopoulos is nearby. I've seen him. You have the chance to see him among us. In fact, I had a question for him. Do you have any more questions concerning all these techniques? We would thank Professor Sountoulidis for his presentation.